Hello, I am Dr. Santosh Abraham. I am working as a specialty registrar in endocrinology and diabetes at Scarborough General Hospital, New York. Today I am going to present adrenal incidentaloma based on the American Association of Clinical Endocrinology guidelines. So we will go through the guidelines and we'll try also to learn a few points on three common topics. More than common, I would tell you that it's very important. Mainly adrenocortical carcinoma, subclinical Cushing syndrome, and aldosteronoma. So the definition: an adrenal incidentaloma is an asymptomatic mass. So it's an asymptomatic adrenal mass detected on imaging. But this is not performed for a suspected adrenal mass. So it excludes patients undergoing imaging procedures as part of staging and workup for cancer. So this will be an asymptomatic adrenal mass that is detected during imaging, but this imaging excludes staging and workup for cancer. In most cases, these are non-functioning adrenocortical adenomas, which means that they don't secrete any hormones. They are hormonally inactive. But sometimes they might require intervention if they are found to be either adrenocortical carcinoma, Pheochromocytoma, a hormone producing adenoma, or if they are part of another cancer and metastasis metastasizing into adrenals. So the evaluation: 3 questions has to be asked when you find an adrenal mass, an asymptomatic adrenal mass on a CT. 1. Is the tumor hormonally active? Is it secreting any hormones? 2. Does it have radiologic characteristics suggestive of a malignant lesion? So does it appear to be malignant on radiology? 3. Does the patient have a history of any previous malignancy? So hormonally active, radiological appearances of a malignant lesion, and previous malignancy. These are the 3 questions, or the 3 points that needs to have a clarification before you proceed. So any patient with an adrenal incidentaloma should undergo evaluation clinically. That's very important for these hormonal excess or for any other features of cancer, and biochemically and radiographically. So this evaluation are for signs and symptoms of hypercortisolism, aldosteronism if hypertensive, presence of a Pheochromocytoma or a malignant tumor. So you need to know the clinical features of hypercortisolism, aldosteronism, and Pheochromocytoma, and you need to evaluate based on that, apart from the biochemical and the radiographical investigations that you're going to perform. So this is a flow chart. When you have an adrenal incidentaloma, look at the size. If it's more than 4 centimeter on the CT, if it's more than 4 centimeter on the CT, or if it's indeterminate, or if it is malignant, you go for adrenalectomy after hormonal evaluation. So if it's more than 4 centimeter on CT, or indeterminate or malignant, you go for the surgery. If it is less than 4 centimeter with benign characteristics, so what are the benign characteristics, which I'll again explain to you in the coming slides. So these are a homogeneous character with regular borders and Hounsfield units less than 10 on a non-contrast CT. So if less than 4 centimeter with benign characteristics, and if they are hormonally active, yes, you do an adrenalectomy. But if no, follow the patient with repeat CT scan and biochemical evaluation. So if you think like this, if it's more than 4 centimeter on the CT scan, or suggestive of malignant lesion, or if you cannot conclude, just go for the adrenalectomy. But if it is less than 4 centimeter with benign characteristics, check for the hormones. If it is producing hormones, yes, go for the adrenalectomy. But if it is not, it's for follow-up. So incidentalomas who do not fulfill the criteria for surgical resection need to have radiographic reevaluation at 3 to 6 months. So the follow-up is at 3 to 6 months and annually for 1 to 2 years. Well, this could differ from the guidelines that has been produced by the European Society of Endocrinology, which I will discuss it in another presentation. Then for all adrenal tumors, hormonal evaluation should be performed at the time of diagnosis. This is very important. So if you find an incidental adrenal tumor, you should never stop, or you should never forget to do the hormonal evaluation. And then for once in every year for 5 years, that's annually for 5 years. So at the time of diagnosis and annually for 5 years, the hormonal evaluation. So all patients should be screened for cortisol excess, and that's done with a 1 milligram overnight dexamethasone suppression test. So this is the simplest screening test. So it's the 1 milligram overnight dexamethasone suppression test. But if the clinical suspicion is high, such as in patients with hypertension, obesity, diabetes, osteoporosis, 3 tests can be used in combination. When you have to make a diagnosis of clear subclinical Cushing syndrome, you look at the levels of serum cortisol. If it is more than 5 milligram after 1 milligram dexamethasone suppression test, and in the absence of typical signs or physical stigmas of hypercortisolism, it will suggest that the patient has got SCS, or subclinical Cushing syndrome, further supported by a low or suppressed level of ACTH or a low dehydroepiandrosterone sulfate concentration. So further supported by a low ACTH or a low DHEAS. Now a second abnormal test to look at the HB axis, such as a 2-day LDST, that is a 2-day low dose dexamethasone suppression test, could also be used with this, and sometimes it may be also needed to establish the diagnosis of subclinical Cushing syndrome. So, are you going to remove the adrenals in patients with SCS? So, until further evidence is available regarding the long-term benefits of adrenalectomy, surgical resection should be reserved for those with worsening of hypertension, abnormal glucose tolerance, dyslipidemia, or osteoporosis. So, if the patient is symptomatic and if the symptom is worsening, well, you can proceed with surgical resection. But if the patient is asymptomatic, surgical resection is not at all recommended. So you have to give perioperative glucocorticoid therapy and do the postoperative assessment of HB-axis in patients with SCS. But there is no need for glucocorticoid replacement intraoperatively in patients with Cushing syndrome. So why you need to do this perioperative glucocorticoid replacement? Excess cortisol secretion from an adrenocortical adenoma suppresses the production of ACTH by the pituitary. So this leads to atrophy of the contralateral adrenal gland that is devoid of the trophic effects of ACTH. So once a cortisol-producing adenoma has been removed, physicians can administer glucocorticoid replacement, glucocorticoid replacement because the remaining adrenal gland is suppressed. So excess cortisol suppresses ACTH and it leads to contralateral adrenal atrophy. So it can't work, and hence when you're removing this adenoma, which is the only source of cortisol, you will go to a adrenal insufficiency. So in order to prevent this, you give glucocorticoids. Normally you give high stress doses, and it is usually weaned step by step, and then as in the management of Addisonian crisis, you titrate it to maintenance dose of hydrocortisone. So postoperatively in Cushing syndrome, if the patient is having Cushing syndrome, the patients should be treated with exogenous glucocorticoids until the HB-axis has recovered. So this amount of the recovery time varies between 6 to 18 months after unilateral adrenalectomy. So if the patient has Cushing's after adrenalectomy, it's important that the patient receives exogenous glucocorticoids until the HB-axis is recovered, and the recovery time is usually 6 to 18 months. So till that time, the patient is expected to be on the steroids. And if you suspect a Pheochromocytoma, definitely the patient should undergo plasma fractionated metanephrines and normetanephrines. So plasma metanephrines and normetanephrines, or 24-hour total urinary metanephrines and fractionated catecholamines. Even though plasma fractionated metanephrines and normetanephrines are more preferred because of the sensitivity and specificity. 1/4 of the patients with Pheochromocytoma will have associated familial syndromes. So these are usually caused by mutations in the RET gene, the VHL gene, or the SDH genes. So that needs to be kept in mind. So genetic study and counseling should be performed, especially for young patients or patients with an extra-adrenal Pheochromocytoma. So in young patients or in extra-adrenal Pheochromocytomas or paragangliomas, genetic studies are very important. And if the patient is known to have a Pheochromocytoma, okay, then you go for a surgical resection, that's for sure. So as I've already explained in my previous presentation, if a patient with a Pheochromocytoma plan to undergo a surgery, preoperatively he or she should receive the alpha-adrenergic blocking agent, because if they don't receive it, there could be intraoperative complications and hemodynamic instability, such as hypertension, intraoperative arrhythmias, and so on. And in patients who had a diagnosis of Pheochromocytoma and who have undergone surgery, long-term follow-up is necessary, because 10 to 15% may have recurrence here. So long-term follow-up in patients with Pheochromocytoma. So how do you do this alpha-adrenergic blockade? It's usually done with phenoxybenzamine. It's started 10 milligram twice daily, and the dose could be titrated up to between 300 and 400 milligram daily in divided doses until the patient becomes normotensive, the hypertension is well controlled, and or intolerable side effects develop, that is orthostatic hypotension, tachycardia, nasal congestion, nausea, or even abdominal pain. So these side effects are actually in fact indicators of adequate alpha blockade, and this alpha blockade is given 1 to 3 weeks prior to the surgery. Why this is done? Because you don't want to have an profoundly unstable blood pressure during the operation. So it's phenoxybenzamine. You will start 10 milligram twice daily, and you will give for 1 to 3 weeks. Meanwhile, you will titrate up to 300 to 400 milligram until you see these signs like orthostatic hypotension, tachycardia, nasal congestion, nausea, abdominal pain. And also you will check the patient's BP and ensure that the blood pressure is really in good control. So indications for beta-adrenergic blockade. This is slightly different from the guidelines in the European Society of Endocrinology. Anyway, here the American Association of Clinical Endocrinologists recommends that the indications for beta blockade are persistent tachycardia, extrasystoles, or arrhythmias. In any case, it should be only started after adequate alpha-adrenergic blockade. Again, propranolol is the drug of choice, and the dose is 10 to 40 milligram every 6 to 8 hours. Now, if the patient is asthmatic, you could use calcium channel blockers preoperatively and intraoperatively for BP control. Now, the patient should be encouraged to have liberal fluid and salt intake before the surgery, because the patient could develop postoperative vasodilatation and blood pressure drop due to the removal of the tumor. Now, screening for aldosteronism also should be performed in patients with incidentalomas. So how we do that? It's usually done by performing the ARR, or the aldosterone-renin ratio. So ARR of more than 20 suggests that the patient could have aldosteronism. So how is it confirmed? It's confirmed by lack of aldosterone suppression. It could be with a 24-hour urine study with salt loading. So screening with ARR, so more than 20 suggests the patient could have it, and confirmation by lack of aldosterone suppression. Now subtype evaluation, it should be performed with HRCT scanning and adrenal venous sampling, that is AVS, in majority of the patients older than 40 years. So AVS is recommended in most of the patients above 40 years. So if you find out that the patient is found to have an increased aldosterone secretion, I mean the tumor is found to secrete increased aldosterone, then a unilateral source of aldosterone should be found out for, because laparoscopic total adrenectomy is the treatment of choice. Why? Because it yields excellent outcomes and it has got low morbidity relative to the open surgery. So if the aldosterone production is unilateral, laparoscopic total adrenectomy. So if the patient is having bilateral idiopathic hyperaldosteronism, obviously he cannot be operated. And if the patient is not a surgical candidate for any other reasons, so they could be managed on mineralocorticoid receptor blockers, that is the EMMA blockers, which could be selective and non-selective. So patients not good for surgery should be managed with the mineralocorticoid receptor blockers. Patients having unilateral source of aldosterone secretion should be managed by lap adrenalectomy. Now any adrenal mass more than 4 cm or having radiographic characteristics should be resected. Why? Because there is an increased risk of adrenal cancer. So radiographic characteristics more than 4 cm in size or indeterminate lesions, go for resection. Before resection or before surgery, Pheochromocytoma should be ruled out. That's very, very important. So if you suspect the patient to have an adrenocortical carcinoma, they should undergo biochemical evaluation to identify any potential hormone excess. Why? Because this could serve as a tumor marker and to determine whether the patient requires steroid replacement perioperatively in case of hypercortisolism. You could also use this potentially elevated, you could also use this hormone marker as a post-op surveillance tool to know whether you have completely resected the tumor or whether the surgery has been effective for the patient. So if you suspect an adrenocortical carcinoma, you are not going to do a lap, but rather you will go for an open adrenalectomy. So for unilateral adrenal adenoma, you go for a lap. But if it is ACC or adrenocortical carcinoma, it is open adrenalectomy. And just before you do that, rule out the Pheochromocytoma. Check if there are any other hormones raised, and make sure that the patient, if the patient needs steroid replacements perioperatively, just keep that. I know this slide is a bit it's a bit crowded slide, but I'll try to summarize this. So I wanted to introduce about the late night salivary cortisol test. So it's a very recent assay, but it's the earliest and the most sensitive markers for Cushing syndrome. So the late night salivary cortisol test. It is one of the earliest and the most sensitive markers. And suppression of plasma cortisol to less than 1.8 has some best negative predictive value for Cushing syndrome. So if you have a positive test, it should be followed by further testing. It would include a night salivary cortisol, or a 24-hour urinary free cortisol, or a 2-day LDST. And UFC is a better reflection of cortisol levels. Why? Because they are not affected by factors that influence CBG or corticosteroid binding globulin. So it is considered to be an integrated measure for excess production of cortisol. So the late night salivary cortisol test, it's the earliest and most sensitive markers for Cushing syndrome, and it's a recent assay that's been developed. And if your patient is screened for Cushing syndrome and it's positive, it needs to be followed up by further testing, which could include the 24-hour urine free cortisol, or a midnight salivary cortisol, or a 2-day LDST. Again, UFC is a better reflection, and elevated UFC, more than 4 times the normal, is diagnostic of Cushing syndrome. And I will tell you a few details about adrenocortical carcinoma. So patients with ACC in general have poor prognosis. 2 determinants of long-term survival are stage at presentation and curative resection. Bear in mind that the curative resection needs to be done by an experienced surgeon. So the screening protocol for adrenal incidentaloma aims at identifying all patients with ACC. In other words, you shouldn't miss any patient with an adrenocortical carcinoma if you find an incidental tumor in the adrenal CT scan. But you cannot diagnose ACC before the surgery, definitively. Why? Because you cannot do a cytological or biochemical testing to prove it. So basically you are looking at the radiology, and the radiographical imaging dictates whether the tumor is malignant or the patient is having the risk of ACC. So if you find out that radiologically the tumor has got features of malignancy, or even if the radiological the tumor is indeterminate, you go and operate. So ACC constitutes less than 5% of adrenal incidentaloma. 2/3 of them are hormonally active and manifest hypercortisolism mainly. Rarely it could also manifest with aldosteronism or features of feminization. But in general, the ACCs manifesting as radiographic incidentalomas are clinically non-functioning tumors. So, incidentalomas with a radiological appearance of ACC are clinically non-functioning tumors for the majority. Even though 2/3 of all the ACCs are hormonally active. So as far as an incidentalloma is concerned, most of the ACCs are clinically non-functioning tumors. I hope you get the message clear now. So if the incidentalloma has an attenuation of more than 10 Hounsfield units, it's concerning. And if you have more than 30, it definitely gives you a radiological diagnosis of ACC. Now the differentials for the ACC are Pheo, METS, lipoadenoma, So why do you need to biochemically evaluate a patient with ACC if you're going to perform a surgery? First of all, you want to make sure that the patient doesn't, the ACC is not a Pheochromocytoma. And also you want to check for other hormones which you could use post-op as tumor markers, as I've told you before. The distinction between a metastatic lesion and a primary ACC can be difficult. But if you got a history of a malignant tumor, so that could probably indicate metastatic disease. So it manifests in patients with prior history of malignant tumor for a primary lesion, or if there is evidence of other mets. How about the FNAC? The CT-guided FNAC will not distinguish ACC from benign adenoma. If there is no mets, an open adrenalectomy for a suspected ACC should be performed. So once again, if you are suspecting ACC and if there are no mets, open adrenalectomy. So detailed hormonal evaluation is critical before surgical resection. High circulating levels of steroid precursors may be found without any clinical signs, subclinical Cushing's as in SCS. Cortisol-producing ACC are the risk of post-op adrenal insufficiency, so they will require post-op corticosteroid replacement. Any hormonal markers identified before resection will serve as tumor markers during post-op surveillance. And patients need to undergo biochemical evaluation for Cushing syndrome and aldosteronism. So I am just summarizing it again, just to make sure that you get the gist of what I'm telling. So radiographic evaluation. The size of the lesion can be a major predictor for an ACC in an incidentalloma with more than 10 Hounsfield units. So when I told you previously that anything more than 10 Hounsfield units, more than 10 Hounsfield units is concerning. So if you have a lesion which is more than 4 cm in size, it favors malignancy. Other features that cause concern for a malignant lesion are irregular shape, inhomogeneous pattern, invasion into surrounding tissues, and thrombosis. So irregular shape, inhomogeneous pattern, invasion and thrombosis. So it's 3 I's and T, like I-I-T. I-I-I-T. You could remember that's irregularity, inhomogeneous, invasion, and thrombosis. Apart from the mass. So open adrenalectomy by an experienced surgeon is the procedure of choice for this ACC. So experienced surgeon, that's quite important. And en bloc resection is done. So the surrounding tissues, kidney, liver, inferior vena cava, if they're involved, they are also removed. Lymph nodes are removed. Usually they leave the capsule intact to decrease the the possibility of local recurrence. So to decrease the chance of local recurrence, the capsule is left. Will you do a lab adrenalectomy in ACC? No. Why? Because there is increased risk of early local recurrence, peritoneal dissemination, and port entry site sealing. So if you have a suspicion of ACC during a lab procedure, just convert it to an open resection. I know it's very easy to say that, but if you have any suspicion of ACC at any point, you need to do an open resection. Now coming to subclinical Cushing syndrome. So it's found in more than 5% of the patients with incidentalomas. It's a poorly defined entity. It could be unique to these incidentalomas. So there is a subtle autonomous production of cortisol which is nearly missed, or which is not noticeable because of the absence of the clinical signs. So this is presumed to be produced by the adrenal tumor, but there is suppressed production of cortisol from the contralateral gland and no overt clinical features. So suppressed production of the cortisol from the opposite gland with no features, with no clinical features of Cushing syndrome, fits the criteria for the subclinical Cushing syndrome. The best proof for this disorder is the development of adrenal insufficiency after the operation. But you don't want to do that, right? So why do these patients have adrenal insufficiency? As I've told you before, long-term exposure to subtle cortisol may lead to metabolic derangements seen in patients with frank Cushing syndrome. And also in SCS, the prevalence of hypertension, obesity, insulin resistance, dyslipidemia are more. So how do you diagnose SCS? It's made biochemically. But there is quite a lot of variation among the diagnostic criteria. So here you use the 1 mg dexamethasone test, which is more sensitive than the UFC. Some of them advise a second abnormal test of the HB axis, such as a 2-day LDSD. It will be always wise to have a consultation with an experienced endocrinologist. Now coming to aldosteronoma, 1% of adrenal incidentalomas, they are drug resistant and they cause refractory hypertension, so you need more than 3 antihypertensives, and they may exhibit spontaneous hypokalemia, that is potassium less than 3.5, or severe diuretic induced hypokalemia. But bear in mind that most patients with primary aldosteronism do not have hypokalemia. So drug resistance and refractory hypertension, they need more than three antihypertensives are the most important. They may have hypokalemia as well, but they may have normokalemia. Other causes of primary aldosteronism are adrenal hyperplasia and pure aldosterone secreting ACC. So unilateral adrenal hyperplasia is an important entity because if it is recognized, the surgical treatment can lead to a reversal of the symptoms and can give a much better prognosis for the patient. Usually these adenomas are solitary, rarely bilateral. So usually they are solitary, usually less than 2 centimeters in diameter. And they are characterized by micronodular or macronodular hyperplasia. So these are usually single, usually unilateral, usually the size is less than 2 centimeters with micronodular or macronodular hyperplasia. Diagnosis and screening. So you determine the ratio of PAC to PRA, that is aldosterone to renin ratio. This is now the accepted screening modality for primary aldosteronism. So when you add the PAC to the ARR, it increases its specificity. Once again, ratios can be lab dependent. Before screening, withhold spironolactone and eplerenone, that they are the MR blockers, for 4 to 6 weeks. And what about diuretics? They can produce hypokalemia, and the ACEs and the ARBs can inhibit the RAS as well. A low PRA in the setting of an ARB or ACE should alert you the possibility of autonomous aldosterone excess. So once again, PAC to PRA ratio, that's accepted screening modality. Specificity is much increased when you add PAC to the high ARR. The ratios are lab dependent, and you withhold MR blockers 4 to 6 weeks prior to the test. So this is a flow chart. So any patients with hypertension or hypokalemia or refractory hypertension or incidentaloma or newly diagnosed hypertension, so the incidentalomas also falls in that. So you assay the plasma renin activity and the plasma aldosterone concentration. If the PAC to PRA ratio is approximately 10, you investigate for other causes of secondary aldosteronism like renovascular hypertension, diuretic use, renin secreting tumor, malignant hypertension, or iatrocoid. If the PRA is decreased and if the PAC is going high, and if the PAC to PRA ratio is more than 20, then that means that there is primary aldosteronism. There is autonomous production of aldosterone. So you confirm it by the lack of aldosterone suppression in the set by giving sodium loading. by loading the patient with salt. So how do you confirm primary aldosteronism? So it is by the lack of suppression of aldosterone levels after salt loadings, which could be done in either of the two ways. In the first method, you add 1 flat teaspoon of salt to the daily food intake and ask the patient to consume salty foods for 72 hours, or you perform a saline suppression test. So here you give an isotonic saline at the rate of 300 to 500 ml per hour for 4 hours. Then you sit the patient and the PAC is determined. So the PAC exceeding 10 is confirmation of primary aldosteronism. In either of these cases. So if the patient had salt-rich food for 72 hours plus 1 teaspoon of salt to their daily food intake, or if you did a saline suppression test and then you do a PAC in the sitting portion, and if the PAC exceeds more than 10, it confirms primary aldosteronism. So APA versus PAH. So the distinction is critical because APA, since it's a tumor, it could be managed surgically with unilateral adrenectomy, preferably a lap. So the lap, usually it's not preferably, it's with the lap done. Whereas the PAH, the adrenal hyperplasia, is managed by the MR antagonists or the MR blockers. So the APA and the PAH constitutes about 95% of all the cases of primary aldosteronism. Clinically, patients with APA, that is the patients with adenomas, are often younger. They have more severe hypertension and hypokalemia. They have higher PAC values and urinary aldosterone, and they respond better to spironolactone. So they are often younger. They have increased blood pressure, severe hypokalemia, increased PAC, and give a better response to spironolactone. So this is a flow chart for the adrenal CT imaging. So if you are doing an adrenal CT scan and if you find a unilateral hypodense nodule, and if the patient is less than 40, you go for the unilateral lap adrenalectomy. So in a unilateral nodule, hypodense nodule more than 1 centimeter, in a unilateral lesion or nodule more than 1 centimeter, if the patient is less than 40, go for lap adrenalectomy. But if the CT is normal, or if it shows micronodularity or bilateral masses or atypical masses, and if you suspect that the patient is having APA, do an AVS, and if there is lateralization with AVS, go with the lap adrenalectomy. But if there is no lateralization, and if there is low probability of APA, we don't go with the surgery. So imaging and localization. Lateralization is very important. The ability to lateralize the site from where the aldosterone is secreted excessively helps you to select the patients for surgical treatment. Why? Because they have a great chance for cure. Well, the CT scan will reduce the number of false negatives, but it also increases the false positives. So young patient less than 40 years with primary aldosteronism who has adenoma larger than 1 centimeter, uniform, hypodense, and a morphologically normal contralateral adrenal gland, they don't need any further imaging or evaluation, and they are candidates for operation or surgery. Older patients with bilateral morphological abnormal signs, or those with a unilateral microadenoma or microadenomas, they need to be considered for bilateral AVS to distinguish adenomas from hyperplasia. Also, if the patient is not a good surgical candidate with limited life expectancy, and if they are comfortable with medical therapy, MR receptor blockers could be used, and they don't need any further evaluation. So before the AVS, the patient should discontinue the use of spironolactone for 6 weeks if they are on eplerenone for 4 weeks. So it's a much operator dependent procedure. Why do you use the aldosterone to cortisol ratio? This is used to account for the dilutional effect on the left side, because there will be mixing of the blood from the inferior phrenic vein. So the corrected aldosterone cortisol ratio of greater than 4:1 are indicating of a unilateral source of aldosterone excess, and they could be managed with unilateral adrenalectomy. So stop spironolactone before 6 weeks, stop eplerenone before 4 weeks. If the AVS shows that the aldosterone cortisol ratio is more than 4:1, it's more suggestive of a unilateral source of aldosterone, and then go for the unilateral adrenalectomy. In some medical centers in the US, they perform AVS in all patients who have the diagnosis of primary aldosteronism, whereas in some they advocate its selective use. So definitive therapy is essential for patients with primary aldosteronism because excess levels are deleterious, even if the hypertension and hypokalemia are adequately controlled. So if they are not treated well, it could lead to myocardial fibrosis, left ventricular hypertrophy, CCF, more ischemia, and increased vascular and clotting issues. Eplerenone is a recently added corticosteroid-based competitive MR antagonist. So unlike spironolactone, it has little androgen receptor antagonist activity, so it does introduce those untoward side effects in men, especially gynecomastia and impotence and menstrual irregularities in females. So unilateral adrenalectomy is the treatment of choice if you find evidence of unilateral aldosterone excess and primary aldosteronism. So why not partial adrenalectomy? In pathological specimens, we've seen that there are additional nodules in the same gland of the patients with a dominant nodule. So if the dominant nodule, even if it's non-functional, if you remove it, there's a very good chance that the other nodules may become hyperfunctioning, and they could again, put back the patient into the previous situation. So you don't do the partial adrenalectomy because of the additional nodules, which could become hyperactive once the dominant nodule is removed. So what are the advantages of unilateral RAP? 100% cure for hyperkalemia, a great improvement in hypertension. About 30 to 60% of the patients don't need any medications. Overall, ladies better than gents. But if you have a positive family history of hypertension, it's a negative predictor for long-term BP control. And if you have an excellent response to spironolactone, it is often predictive of successful result from adrenalectomy. I mean, that in those people, the adrenalectomy will work good. So if flap cannot be done because of any issues, a posterior endoscopic or open approach can be used. Large aldosterone secreting tumors more than 6 cm with non-contrast CT attenuation more than 10 Hounsfield units. So large tumors more than 6, even though the attenuation is not is only more than 10, they should be suspected. They should be considered to be ACCs, and it should be managed by the open surgical approach rather than the lab. So if the tumor is more than 6, even if the attenuation is only about 10, go for the open surgical approach. So this is just a slide to show you about the preparation of the surgical procedure. So you give the MR antagonist along with other antihypertensives and cardiac medications. You replete the potassium, and postoperatively KCL is continued until normocolemia can be maintained. So MR receptors are stopped before the surgery, and all antihypertensives are withheld until the BP is normal. So they could be weaned off. Normotension could take weeks or months to achieve. So during the post-op period and the perioperative period, beta blockers should not be stopped abruptly. And if the patient is having ischemic heart disease, they might need to be continued. Thanks for watching this presentation. I'll come up with another presentation, adrenal incidentaloma, based on the European Society of Endocrinology's guidelines. Thank you once again.